Hello and welcome to this webinar about the impact of COVID-19 on Indigenous populations. I'd like to start by acknowledging and paying respects to the traditional owners of the land on which I'm joining you from today, the Ngunnawal people. The Academy also acknowledges and pays respects to the traditional owners and elders, past, present and emerging, of all the lands on which we operate, live and work. They hold the memories, traditions, cultures and hopes of Aboriginal and Torres Strait Islander peoples of Australia. I'm Paul Richards from the Australian Academy of Science. This event is the fourth in a series of COVID-19 events being delivered by the Australian Academy of Science in collaboration with the Department of Industry, Science, Energy and Resources. These events are delivered under the Australian Government's Regional Collaborations Program, which increases international scientific collaboration through research and innovation. Each event in the series will delve into the research that is helping to fight the COVID-19 pandemic and features researchers from different countries. To begin with, please welcome the Deputy Head of Mission and Counsellor at the Australian Embassy in Mexico City, Bernard Unkles.
My name's Bernard Unkles and I'm the Deputy Ambassador at the Australian Embassy in Mexico City. I'm here on the campus of one of Mexico's most prestigious universities, the National Autonomous University of Mexico, standing in front of their main library, an incredibly iconic building. As you can see, on the mosaics behind us, there are pre-Hispanic motifs. And the reason I'm standing here in front of this is not only because today's webinar is all about COVID-19 and Indigenous people, but also because, like UNAM, like this building, the Australian Academy of Science is located in an incredibly iconic building on one of Australia's most prestigious university campuses, that of Australian National University. Mexico's been hit hard by the COVID-19 pandemic. To date, more than 2.3 million people have tested positive for COVID in Mexico, and more than 215,000 deaths have been confirmed. The unofficial figure is unfortunately significantly higher. Mexico's Indigenous population has in particular been hit quite hard. In fact, according to a recent study that was published this month in the journal Public Health, and that was undertaken by researchers at this very university, in Mexico, COVID fatality amongst the Indigenous population is 65% higher than amongst non-Indigenous people in Mexico. In Mexico, Indigenous communities have limited and sporadic access to health services, and like in Australia, Indigenous communities are more prone to serious health conditions such as high blood pressure, obesity and diabetes and heart conditions, and as such they're more vulnerable to contracting hard COVID and long COVID. And so the importance of science has never been greater to kind of address a lot of these issues. And collaboration in science is incredibly important as well. Mexico and Australia have a very long and proud history of research collaboration in the sciences. In fact, we signed a bilateral agreement testifying as such back in 1982. To date, our top research fields have been in biology, in physics, in astronomy, and in earth and environmental sciences. But it's also growing recently in fields such as artificial intelligence, tropical agriculture, and also in advanced manufacturing. Scientific collaboration thus far between Australia and Mexico hasn't really touched on Indigenous health issues, but I'm hoping that after today's webinar, this might be the beginning of a beautiful relationship between Australian and Mexican researchers and research institutions. So without further ado, I thank you all very much for your participation in today's webinar, and in particular, I thank the Australian Academy of Science for hosting it. I hope you enjoy yourselves.
Thank you, Bernard. Now to our audience. You'll have the opportunity to ask questions to our speakers. So if you have a question, please email events@science.org.au or on Twitter, tag science_academy and use the hashtag FightingCOV2. Around 3 million people have died from COVID-19 since the pandemic began. The crisis has also devastated the economies and health of many more millions of people. But the pandemic poses an even bigger health threat to Indigenous communities around the world, many of whom have poor access to healthcare and higher rates of disease. So what's being done to help manage healthcare in communities that need it most? And how are Indigenous people helping to provide their own solutions? Joining me to discuss these issues are Indigenous experts from around the world. Dr. Dawn Casey is from Tagalaka country in North Queensland here in Australia. Dawn is Deputy CEO of the National Aboriginal Community-Controlled Health Organisation and currently co-chairs the COVID-19 Indigenous Advisory Committee. We also welcome Associate Professor Margaret Moss, an enrolled member of the Mandan, Hidatsa and Arikara Nation, 3 affiliated tribes of North Dakota in the United States, and has equal lineage to the Sioux Saskatchewan and from the School of Nursing at the University of British Columbia in Canada. And from Mexico, we have Dr. María Graciela Freyermuth Enciso from the Center for Research and Higher Education Studies in the Social Anthropology, as well as Dr. Sergio Meneses Navarro, who is a researcher at Mexico's National Public Health Institute. Translation to English for Graciela and Sergio will be provided by my colleague, Nancy Pritchard. Now let's start with you, Dawn. We have put a number of measures in place here in Australia to limit the spread of COVID-19, including strict border controls and snap lockdowns. What's been the impact on Indigenous Australians since the pandemic began?
So I think it's important to acknowledge traditional owners around Australia, and also I'd like to acknowledge Indigenous communities right around the world. So what was very interesting with our community control health services, which are 143 across the country, was that in fact they were the ones who initiated way back in January and February, together with our peak organisation, the closure of borders. Particularly around the remote communities across Queensland, Northern Territory and Western Australia. So that they were well aware of what could happen if COVID were to make its way to our Aboriginal and Torres Strait Islander communities. So they were on the front foot right from the start. And the government at the same time set up a joint advisory committee, which I co-chair, together with those Aboriginal doctors from around the country, the Commonwealth and state governments, and other clinicians on the advisory committee to advise the government. And we've continued that right up to now, and it will continue for some time in the future. So people were very aware of the impact COVID could make, particularly after the flu in 2009, which killed 24 Aboriginal people in this country. So they did everything to prevent COVID entering their communities right around the country, whether it was in an urban situation and in remote communities. So they created their own awareness campaigns on the ground, reminding people about social distancing, you know, being across the whole area of what the impact of COVID could be. So the end result has been to date that we've had 151 Aboriginal and Torres Strait Islanders contract COVID, but there's been no deaths in the community.
We're very fortunate for that relatively low impact, and it sounds as though the response was excellent. Are Indigenous Australians more at risk if they contract the virus?
Absolutely. So Aboriginal and Torres Strait Islander people have 2.3 times the burden of disease of other Australians. The other issues that we're very conscious of, with our community controlled health services, is a substantial overcrowding in housing, the high risk of comorbidities, and so we're all aware of that, just so conscious about all of the areas that we needed to address. We did modelling, we can tell how many Aboriginal people, as soon as they contracted COVID in urban areas, we have contact tracing in place. So we're just vigilant and remain vigilant the whole time. And have lobbied government really strongly. And I have to say that the government has listened right from the start of this and treated community-controlled health services equal partners in delivering the response and assisting us deliver the response to COVID.
So what have community-controlled health services and governments done exactly to protect Indigenous Australians? Can you go into a little bit more detail about that response? And overall, it sounds as though it's working. Are there any things that could be done even better?
Well, first of all, they listened to the request to close down borders, and they were able to do that because in the Commonwealth's own territory, the Northern Territory, they were able to do that themselves, and then work with the state and territory governments in others to close down those borders. That was really, really critical to do that. The other area was to contribute to the modelling of what would happen in these particularly remote communities if it went through those communities. They provided funding. We didn't wait for the funding, I have to say, in Aboriginal and Torres Strait Islander health services. We went out in the front foot to start with the communications to our communities, but the government did come through with funding. They also allocated funding and additional what we call point of care machines to test COVID so that you can get a response as to whether or not people have COVID within 45 minutes, which was critical if then you were needed to lock down a particular community or lock down particular houses. So they've been extremely helpful in listening and taking on the advice of our Aboriginal and Torres Strait Islander experts who deal with Aboriginal chronic disease management for almost 50% of our Aboriginal and Torres Strait Islander population.
Thanks so much for that, Dawn. Graciela and Sergio, to you now in Mexico. Now, we understand that the pandemic has hit your country very hard, and we thank you for taking the time to be with us and hope that you and your family are staying safe and well. Graciela, first to you, around 2.3 million people have been infected and more than 200,000 lives have been claimed. Has the Mexican government provided detail about the proportion of those that are from Indigenous communities?
Datos en donde se encuentran dos variables que identifican a la población indígena. Una de ellas es la autoascripción indígena y la segunda es si es hablante de lengua indígena. Yo creo que es muy importante señalar que la mitad de la población indígena vive en las grandes ciudades y en los polos de desarrollo y otra parte vive en regiones particulares que se caracterizan por estar dispersas en el área rural y ser de gran marginación. En estas comunidades rurales dispersas es en donde encontramos las más altas tasas de letalidad, que son alrededor del doble de del resto de la población.
Yes, this is a success of this administration. There is a government COVID-19 open database, and there are two variables to identify Indigenous populations. First, self-registration as an Indigenous person, and second, being an Indigenous language speaker. It should be pointed out that half of the Indigenous populations live in large cities or areas that are in development, whilst the other half lives in dispersed rural areas that are highly marginalized. The Indigenous people who live in these regions have a fatality rate twice that of the rest of the population.
Graciela, poverty and a lack of access to healthcare is a problem facing many Indigenous communities around the world. How serious are these problems in Mexico?
Yo creo que en México también son problemas serios. En la población indígena, el 70% vive en pobreza, ¿sí? Para que veas la magnitud del problema. Además, la relación de la población indígena con los servicios de salud ha sido bastante complicada históricamente. Es por eso que se han dado los conflictos que estaban ahí, se han evidenciado más con la pandemia. Por ejemplo, en algunas comunidades se ha difundido que son estas unidades médicas las que están dispersando el COVID-19. Por otro lado, una gran cantidad de unidades médicas de primer nivel cerraron sus puertas y entonces las personas tampoco tienen acceso en ese sentido. Y un tercer elemento que han evidenciado este conflicto es que los prestadores de servicios de salud que viven alejados, que viven en otra localidad y no en la que trabajan, no se les permitió el ingreso a estas localidades pensando que podrían ser una fuente de contagio. Entonces, sí vemos que la pandemia agudizó los conflictos que ya estaban presentes en la relación médico-paciente. Además, la población indígena ha decidido, la gran parte de ella, de hacer sus tratamientos con la medicina doméstica y quedarse en casa independientemente de la gravedad de la situación.
Yes, these are serious problems since 70% of the indigenous population lives in poverty. And also the relationship between health personnel and indigenous populations has historically been conflictive due to discriminatory treatment. This was exacerbated by the pandemic, and in some communities, an idea has spread that public health units are sources of contagion. Primary care health services have been closed in rural areas, and even in some places, residents have prevented health personnel from entering the towns because they do not live there and are seen as a mode of transmission.
Well, that's a really big challenge. Graciela, with the mounting severe cases of COVID-19, many hospitals in Mexico City are close to capacity. What sort of healthcare is being offered to people from disadvantaged communities, such as indigenous communities?
Bueno, primero habría que decir que el sistema de salud en México ha cruzado por una crisis estructural. Y esto se ha reflejado en la última década en que el presupuesto se ha estancado, en que no ha habido una ampliación de la cobertura y de que se han tenido problemas logísticos para obtener medicamentos e insumos. Entonces, esto además, evidentemente, se ha empeorado con la pandemia. El gobierno de México, habría que dividir, el gobierno federal ha implementado toda una serie de acciones dirigidas a esta población. Por ejemplo, se realizaron campañas de información en distintas lenguas indígenas en todo el país. Hay 68 grupos indígenas en México. Y además se creó un modelo de atención para poblaciones rurales, incluyendo a las poblaciones indígenas. Un modelo de atención muy, muy bueno. Pero ¿qué es lo que pasa? El gobierno federal da los lineamientos y es el gobierno subnacional el que puede aplicarlos. Este nuevo modelo no trajo consigo un presupuesto especial. Es así que la puesta en marcha de este modelo estaría relacionado con las capacidades de cada nivel subnacional y sobre todo con la voluntad política. Además, creo que es importante señalar que en México los servicios de salud están descentralizados y también hay cierta autonomía en los estados y también en el caso de la población indígena. Es así que la población indígena puede aceptar o no los lineamientos que está marcando la federación. Por ejemplo, en la vacunación ha habido cierta renuencia para aceptarla dentro de cada comunidad.
The health system has had a structural crisis. In the second decade of the 21st century, the budget has stagnated, the infrastructure has stopped expanding, and has faced logistical problems in the supply of medicines and other supplies. The pandemic has seen this get worse. The federal government of Mexico has promoted a communication campaign in indigenous languages to raise awareness of the issue and also a model of care for this population. And we should be reminded that Mexico has 68 indigenous groups. However, these approaches have not been accompanied by specific additional funding. And in a decentralized health system, implementation of these measures are a state or local function and depend on the political will and local economic capacity, which are usually limited. In addition, indigenous municipalities or local governments have autonomy to set aside and not follow the guidelines on the containment of COVID-19.
It really is a huge problem that you're facing and tackling. Thank you so much for those insights, Graciela. Margaret, you've worked in nursing for decades in America and now as an associate professor of nursing in Canada. You also have Native American and Canadian Sioux Saskatchewan lineage. Apologies for not pronouncing that very clearly. Tell me, how have Indigenous populations been affected in North America?
Knowledge speaking to you all today from the ancestral, unceded, and traditional lands of the Musqueam people. There are several issues related to this COVID-19 pandemic in Indian country, which is an actual legal term to include trust lands, pueblos, reservations, and so forth. So I'll use it here. And again, yes, I am coming from a U.S. perspective mostly. I've only been in Canada for a couple of years. So COVID had hit Indian country with great force. As of February 7th, there's been 181,576 cases of COVID among American Indians, and that's as reported by the Indian Health Service. But the Indian Health Service only serves about 2.2 million American Indians, and the census tells us there are about 5.5 to 6 million American Indians, Alaska Natives in the United States. So right away, numbers can be off, and I can talk a little bit about that later. So what does that look like? Nationwide, 1 in every 475 Native Americans has died of COVID since the start of the pandemic. You can compare that to only 825 white Americans, 645 Black Americans. So by far, they're taking the biggest hit. One study on 23 states found the infection rate was 3.5 times that for whites. There is variance across states, wherein though some, as in New Mexico, can be almost 15 times higher than that for white people. So American Indians and Alaska Natives were also nearly twice as likely to die from COVID as compared to non-Hispanic whites, according to CDC. That was a December 11th information report. And right now it's gone even higher to 2.4 times the deaths from as compared to non-Indigenous in the United States. So people with heart disease, diabetes, lung disease are more likely to be hospitalized and 12 times more likely to die due to COVID. So American Indians already have high rates of these underlying conditions. They have the highest diabetes rates in the world in the Pima tribe, and I believe it's California. It's 10 times the rate of any other group in the United States. So they have already asthma, diabetes, heart disease, and so forth. So Indian Health Service, again, it's a governmental agency to take care of health to a certain extent of American Indians. It does show variability, but at one point, the Navajo reservation, which is the biggest one in the United States with about 300,000 people, had the highest rates. If it was a state, it would have been the highest state for COVID rates. And it's very remote in the southwest of the US. One little problem, the last thing I'll mention is there's a misclassification problem in the United States of American Indians. So once people were moving off of the reservations, which I believe it was 1990 when more than half moved off. It was the first time more than half were off reservation. Once they filter into the urban areas, the numbers get completely fuzzy. So whatever numbers we have, they're probably much, much worse.
Yes, but some really chilling numbers that you just gave us there. And historically speaking, also, as you mentioned, Indigenous people in North America have been impacted by diseases brought into the country like smallpox, TB, HIV, influenza. Can you give us some sense of how much higher a risk Indigenous populations are of infection with COVID-19?
Sure. They talk a lot about the underlying risk factors. Many of them are chronic diseases with heart and with the heart disease and diabetes and so forth. And people think of infectious diseases as largely gone, but not so in Indian country again. TB, tuberculosis, and again, these are some CDC, Center for Disease Control, a government agency in the U.S., is 8 times the rate for non-Hispanic whites, and that's in good times. This is before the pandemic. HIV, although it's low at 0.5% of cases, American Indians are roughly 1.5% of the population. So overall, it's low rates, but it is higher as compared to whites in some categories, such as young men, which is much higher, and women. American Indian women is higher by several times than for white women. When you come to the flu, it's already a big risk in Indian country. American Indians, Alaska Natives have the highest flu-related mortality already, and it's a leading cause of death, and that is numbers as of 2019, just before the pandemic. So flu was already killing American Indians much at a greater rate before this came along. There's no great definitive answers as to why, but there's all those historical factors that some others of you have mentioned. Again, in the U.S., there's these things called federal policy periods over the last couple hundred years, and it's termination and relocation and assimilation and reservations and all these things that have pushed people out where access is low and there's not great care, and so there's all these sort of factors going in. So the infectious diseases are still much worse in American Indians even before the pandemic.
Yeah, it really paints a picture of how huge the challenge is. And the United States has had more than 500,000 deaths due to COVID. How are health authorities helping Indigenous communities, and is that help having an impact?
Yeah, the United States, as you all probably know, is a little different in that we don't have official health authorities. It's still privatized and employment-based insurance and so forth. However, there is Veterans Care and Indian Health Service, which are two probably what you would think of as national programs, but there's no quote-unquote health authorities per se. So it's very disjointed, because in regards to American Indian healthcare, it's considered the ITU system, standing for Indian Health Service, which is the government-to-government federal trust responsibility related healthcare that, due to treaties and so forth, and ceded lands, the government is to help take care of the health of American Indians. It's not always the greatest. And then the figures are that, as I said, most people are off. So 78% of American Indians are off reservation. So then the T is tribal care, and that is for people who, some of the tribes have not disbanded, they've gotten away from the Indian Health Service, which is federal health care. They do their own health care called tribal. It still gets some monies from federal government. And then U is the urban care. Unfortunately, the Indian Health Service is only funded regularly around 50% of need. So you have the sickest people with the lowest life expectancies in the US, and they get funded by Congress at 50% need, sometimes 40, sometimes 60, but it's never even close to being fully funded. Then you take 1% of that funding, and that goes to urban care. So if 60% of people are in urban care, they're getting 1% of an already 50% budget. So it's not great. There's not a lot of coordination. But what has happened is the tribes have stepped up and coordinated fairly well, but again, that's only about 22% of the people over there.
Yeah, wow, I mean, encouraging to hear that there has been some help, but obviously a long way to go. I'd like to head back to Australia now, to you, Dawn. You mentioned things, relatively speaking, are going okay in terms of providing health support. Have there been other disruptions to Indigenous Australians because of the virus, to their way of life, to their education, their ability to seek health support?
Yes, of course. And it's very interesting just talking on this panel this morning how I reflected way back. So certainly education was disrupted when commercial flights ceased in this country from our remote communities. Those students who had to travel away for secondary education, that ceased, and there was a worrying time when closures of borders with children, people had to make their choices about whether they left their children at schools in capital cities and other locations. So that was certainly a big issue of education, and also people, our communities are very protective of young ones and older ones, so they were just very, very nervous about allowing them to go to school, even though there was no particular threat in that area. So that was an area. When people closed down borders in urban areas, and people, the wider population were buying up stocks of toilet paper and sanitizers and pasta and all of that, that had a big impact on Aboriginal communities because they're on the lowest socio-economic strata in this country. They don't have lots of money in the bank to be able to stock up like that and live from week to week. So our health services were finding, not only in remote locations, but looking after people in terms of food, ensuring that they had access to food, etc. The other issue was the need to get out protective equipment, even though there was border closures, etc. So we found our role as the peak body distributing protective equipment, hand sanitizers, etc. So there were large impacts on just everyday life for Aboriginal people. The other area we were concerned about to start with was the chronic disease management, of which we've heard about the United States. Well, our people suffer the same sorts of chronic diseases, and so we had to remind our health services to keep the chronic disease management going, access to medicines going, and it was very, very helpful with the government introducing telehealth, which greatly assisted our certainly not only other Australians, but our health services in continuing the management of chronic disease. So it just every aspect that impacted on broader Australia had a double effect on our Aboriginal and Torres Strait Islander communities in this country.
Okay, I guess a silver lining in all this, Dawn, is some of the innovations that have come about throughout the pandemic. You've mentioned a couple already, telehealth being another one to be able to provide health support via a telephone or other communications. Tell me a bit more about the innovations that have helped to protect Indigenous Australians.
Yes, well, that was telehealth was great because the government has been doing a review of Medicare benefits scheme billing for a number of years, and so telehealth, the advent of that just really brought compressed all the time, so we're able to address a whole lot of things because many of our remote communities don't necessarily have access to general practice and other specialists, etc. And it's becoming increasingly difficult for Aboriginal and Torres Strait Islander people, but also wider with the white Australian population in these remote and rural areas to attract nursing staff, GPs and other practitioners. So the fact that we've got fantastic Aboriginal practitioners on the ground, the access to telehealth in terms of was a huge benefit, and also assisted the contribution to the the financial aspects of community controlled health services. The other amazing was the point of care test, which had been rolled out 2 years prior in terms of congenital syphilis, where there was a bit of a reluctance by our clinicians because of the false positives it could return. And also the research being done by universities using point of care tests for gonorrhea, chlamydia, and gene expert machines for that. The government adapted those with the research areas to for the COVID testing, for instance, and we were able to place those with communities that had more than 2 hours distance between pathology. So that's a great innovation. And as soon as we're over with the threat of COVID, that they will be left around the country in places that wouldn't have normally had access to these machines for dealing with BBVs and STIs and other, with further development. So it's been just that's a silver lining for us in terms of COVID, and we're urging the government to continue with some of those developments in an ongoing way, which I think they're really listening to.
Yeah, that's very encouraging. As we know, and many Indigenous communities are spread across the country, both in urban areas, but also sometimes in quite remote areas. And Australia, like many countries, is in the middle of rolling out COVID vaccines. How is this going to work in our Indigenous communities?
So our community controlled health services, unlike the United States, we started these in urban and mainstream areas because of the racism felt and still felt today by Aboriginal and Torres Strait Islander people in this country. So our oldest health service in Sydney celebrates its 50th anniversary this year. So they've played a major role in creating a culturally safe place for people to go for all of their chronic disease management, clearly, and immunisation. So we've got a really good track record across the country with flu vaccination is much, much better than non-Indigenous populations. So the government has recognised the high benefit of our community controlled health services. So 107 of them across the country registered to roll out the COVID vaccine, and we're well on track to do that. Clearly, we've been hindered the last 3 weeks with the issues around AstraZeneca and the government's guidelines around the preference would be not to use AstraZeneca for under 50s. So the majority of our population are under 50. So currently, we'll have a big meeting today, in fact, to look at how do we deal with the joint Pfizer versus AstraZeneca rollout. But certainly a big, and there's some hesitancy by our communities, unusual hesitancy, but particularly around our clinicians in our community controlled health services. So we just need to work carefully over the next few weeks, as we have been, with the already existing rollout that has occurred around AstraZeneca and Pfizer for the allocated areas. So it's tricky at the moment. We're a victim of our own success in that we haven't had any deaths in our community from COVID, and we certainly won't want that to happen when they're sort of from injections. So it's careful. But still encouraging, because if it gets into the communities, it's still around, it will have a massive impact.
There hasn't been a severe impact, fortunately, in Australian Indigenous communities of the disease itself. Then being motivated to get the vaccination is another step that takes some careful communication.
That's
Sergio,
right. So I was just going to make one more comment around that. That's exactly right. So the community doesn't see or take note of the big issues in India currently and other areas, but on social media they see the impact of blood clots and that. So it's a balance of trying to encourage people.
Very good. Yeah, thank you, Dawn. Sergio, to you now. Mexico was one of the first countries in Latin America to start vaccinating people. So far, around 6 million have received the vaccine. What are some of the challenges you've been facing?
Y gracias por la invitación. Mira, nosotros identificamos tres principales retos. En primer lugar, pues el reto de conseguir justamente la vacuna. En ese sentido, nos parece que México lo ha estado haciendo razonablemente bien. Por cierto, ya llevamos cerca de 20 millones de dosis aplicadas. Esto es una buena noticia y nos permite pensar que probablemente para finales de este año tendremos un porcentaje amplio de los casi 130 millones de mexicanos. Es una población grande. El segundo reto es superar la desconfianza y el rechazo. Ya Graciela ha hecho mención de que desde el principio de la pandemia hubo algunas muestras de rechazo de parte de las poblaciones a las medidas sanitarias respecto al COVID. Algunas de estas muestras de rechazo fueron incluso violentas. También se han manifestado ya algunas expresiones de rechazo a la vacuna, incluso por autoridades de municipios completos. Y el tercer desafío es logístico. ¿Cómo llevar la vacunación a los cientos, en realidad a las decenas de miles de localidades dispersas en regiones de difícil acceso y algunas de ellas en las que también existe dificultad relacionada con el crimen de inseguridad debido a la presencia de la delincuencia organizada?
Thank you, Paul, for inviting me to this webinar. I identify three main challenges for the vaccination of Indigenous populations. The first challenge is precisely getting hold of the vaccines. In this sense, it seems that Mexico is doing reasonably well. And by the way, we have already applied almost 20 million doses. And probably this year, we will be able to vaccinate a high percentage of almost 130 million Mexicans. The second challenge, which Graciela alluded to previously, is to overcome the mistrust and rejection. Since the beginning of the pandemic, several Indigenous communities have expressed their rejection, sometimes violently, of health interventions related to COVID, including vaccination. The third challenge is logistical: how to bring vaccination to Indigenous regions, to dispersed communities, difficult to access, and in some places where the presence of organized crime prevails.
Sergio, as we heard from Dawn, the pandemic has other impacts on Indigenous populations. How has it impacted Indigenous populations in Mexico in areas such as education and employment?
Sí, gracias, Paul. Mira, lamentablemente con la pandemia, la pobreza en México se ha incrementado en 9% en este año que llevamos de pandemia. Ya más de la mitad de los mexicanos, 52%, se encuentra en condición de pobreza. Pero la pobreza extrema se ha prácticamente duplicado. Entonces, bueno, en ese sentido hay un impacto importante. Respecto a la educación, pues la infancia indígena se ha visto seriamente afectada, principalmente por dos razones. En primer lugar, porque quedaron como responsables de la educación de los niños las mamás, que son quienes suelen tener una menor educación y también una menor destreza en el manejo de las tecnologías de la comunicación y la información. Y por otro lado, porque también los hogares indígenas son los que tienen un menor acceso a Internet y a dispositivos para la educación a distancia. De ese modo, pues ya se ha registrado una importante deserción escolar entre la infancia indígena. Y respecto al empleo, debemos recordar que una gran proporción de la población indígena ha migrado por motivos laborales, pero en este momento pues perdieron el empleo y regresaron a sus comunidades. Por cierto, este regreso ha tenido algunos efectos paradójicos. Por un lado, el temor al contagio de COVID y en algún momento se trató de impedir el regreso de los migrantes, pero pues pudo más, digamos, el afecto familiar de las familias que recibieron a los migrantes que hacía años probablemente que no veían.
With the pandemic, poverty has increased by 9% to up to 52%, and extreme poverty has almost doubled. In relation to education, Indigenous children have been affected for two reasons. Firstly, because their education was left in the hands of mothers, who in general tend to have a low level of education and less skill in the use of information and communication technologies. And secondly, because Indigenous households have less access to the internet and devices for distance education. Thus, there has already been a high dropout rate. With respect to employment, with the pandemic, several Indigenous migrants to cities lost their jobs and had to return to their communities. The massive return of migrants to the communities of origin had contradictory effects. Attempts were initially made to prevent migrants from returning, fearing the spread of COVID. But at the same time, the families reacted with joy at the reunion of the children, husbands, parents, whom they had not seen in a long time, even many years.
Wow, it really paints a broader picture of it, just the knock-on effects of this virus on Indigenous communities in Mexico. Sergio, what future plans does Mexico have to try to improve the containment and spread of COVID-19, especially within Indigenous communities?
Bueno, en este momento principalmente la prioridad es la vacunación. Ese es el plan en el corto plazo. Pero por supuesto, a largo plazo es necesario fortalecer la atención primaria en salud de manera integral, de modo que nos permita brindar una respuesta, por supuesto, a la emergencia de COVID, pero también a otras condiciones de salud que han sido desatendidas por la pandemia, como las enfermedades crónicas, el tema de las mujeres embarazadas u otros temas de salud reproductiva, por ejemplo. Es una tarea complicada porque se requiere el fortalecimiento de todo el sistema de salud y eso implica además pues incrementar de manera significativa su presupuesto. Nosotros pensamos que en realidad se tiene que duplicar y eso significa un aumento de más de 3 puntos porcentuales del Producto Interno Bruto.
So the focus at the moment is obviously the vaccination, but strengthening primary health care in a comprehensive way so that the model proposed by the Mexican federal government can be effectively implemented and deal with the COVID emergency, but also take care for the rest of the health conditions that have had to be delayed through the pandemic, such as women's reproductive health and women who are expecting children. This is a complicated task and requires a complete strengthening of the health system by increasing the budget by at least an additional 3% of GDP and improving the design of the health system to ensure universal coverage.
Thank you very much, Sergio. I'd like to open up to some questions from our audience. We've been getting some terrific ones through. I'll do that in a moment. I have one final one that I've prepared that I wanted to ask you, Margaret, first. Vaccination, the rollout is underway in the United States. How are they being received in Indigenous communities?
So in Indian country, there's already low life expectancies. I think people would be surprised to find out that, for instance, in the Dakotas, both my reservation, there's many reservations across Dakotas, Montana, but some of the more desperate ones have a life expectancy for males today in the 40s and for females in the 50s. This is some of the lowest life expectancies before the pandemic, not just in the Indian country or US, but in the Western Hemisphere, sometimes tying with Haiti. So these are if you look at the global numbers across the or the national numbers, it doesn't look as bad, but the minute you start drilling down into some of these reservation-based communities, it gets quite desperate. So with already low life expectancies, high incidence of infections and chronic disease, as I've stated, those are all already in place before the pandemic. Then they have some of the lowest employment rates, high poverty rates, all of the socioeconomic status numbers. Now you add in great distances, lack of water, multi-generational households, low access to healthcare, and so forth. Around the water issue, again, I mentioned Navajo, which is a huge reservation in the Southwest, and they don't, in many cases, don't have water. You can't just turn on a faucet. They have to wait for the water lady and the truck to come by. Now, think in the beginning of the pandemic when we said, wash your hands, wash your hands, wash your hands. If you only have this much water, what are you going to do? You know, so but nobody helped in that area at all. Nobody's even thinking of it. Everybody's just used to turning on water. So there's all these problems that start with structural determinants of health, the lack of funding, these policy periods that put people way out in the middle of nowhere, which lead to the social determinants of health and then the manifesting in this. So trying to get vaccinations out to people who are very far out. In my case, again, North Dakota is a very cold place in the winter. So I heard from some elders who had to travel over, you know, country roads on ice in minus 40 degrees to try to get to vaccination. They get there and it's closed or it wasn't available and they had to go back. So are they going to come out again? So there's still all of these technical issues, even if vaccines are available. So again, the numbers coming across are that reservations now, it's not as desperate as in the winter, were given out to tribal communities. Again, the urban population is not doing as well in trying to get vaccinated. So it's sort of a mixed bag. If you are on a tribe, tribal nation that has the vaccine program, then you have access to it now. It's kind of desperate earlier and in the winter. But again, the numbers are way off for the urbans.
Okay, yeah, thank you. That really paints a picture of the challenge. I'd like to get through as many audience questions as possible in the minutes that we have remaining, and I'd like to ask the first one of you, Margaret. This was sent in by one of the fellows of the Australian Academy of Science, Professor Linda Blackwell. She asks, how do we ensure that Indigenous populations are fully kept in the loop of complex COVID-19 matters, vaccination as well as detection in the environment?
Yeah, it's somewhat difficult in the U.S. context because there is no interplay between the various tribes, and there are, again, 576 of them. So if you are a part of the Indian Health Service, then you can get the governmental agency information out. If you are in urban areas, you're going to have a different system, and it's going to be the U of the ITU system. And those are largely, as you said, NGOs, nonprofits, and it's however they get things out. So it's going to be different portals, different places. And then the tribes themselves have their own ways of communicating, but it's usually not tribe to tribe. So either things are coming from the federal government into Indian Health Service, or it's tribes themselves coming to their own people. And the urban area is very splintered. There is no one. I can say with quite a lot of confidence that Indian Twitter and Facebook is where a lot of people get their information. It's not some coordinated governmental or tribal source, really.
Yeah, it really speaks to the need to provide that information where people are accessing it as well. Graciela, I'd like to ask a question of you. This was sent in by Marvin Vasquez. And Marvin asks, what is the role of NGO, national government, non-government organisations, in the attendance and support of these communities during the pandemic? Are they helping on vaccination campaigns as well?
Bueno, yo creo que las actividades de las organizaciones no gubernamentales han sido muy importantes desde el inicio de la pandemia, porque ellas empezaron, o sea, no dejaron de ir a campo. Entonces han dado un seguimiento estrecho de lo que ocurre en las comunidades indígenas, los problemas que se gestan y qué es lo que hay que hacer para enfrentarlas. Este seguimiento y estos elementos que han ido documentando han realizado propuestas de política pública tanto en el nivel subnacional como en el nivel federal. Entonces, creo que este fue uno de sus acciones más importantes. La segunda ha sido las campañas de difusión. Por ejemplo, en estos momentos, en la campaña de vacunación, han hecho un trabajo muy intenso entrevistando a las mujeres que se han estado vacunando y por qué se están vacunando, para difundirlo en las comunidades y ver que hay personas indígenas que están aceptando la vacuna y cuáles son sus argumentos. Entonces, esto también, estas campañas que han sido, se han realizado en diversos municipios del estado de Chiapas y de otros estados, han sido también muy importantes. Y también tuvieron un papel fundamental para proveer de equipo de protección, por ejemplo, a las parteras tradicionales, que fueron las que empezaron a atender todos los partos que se daban en estas comunidades, ante pues la duda de acudir a los hospitales por parte de las mujeres. Entonces, creo que el trabajo que han hecho las organizaciones no gubernamentales ha sido importante en esta pandemia.
So the role of NGOs has been a very important one, and they have been very effective right from the beginning of the pandemic. They have been there, they have provided support, and they have followed and documented everything that has been happening in these regions. And this has been done both at the federal level and at state and local levels. There has been a very strong campaign for vaccination, and it has had a focus on women and women who have been vaccinated, and so that people in the communities can see that women are taking the vaccination, and for there to be a better acceptance of the vaccination in various states of Chiapas, which is the south of Mexico, and others. And of course, the third thing that they have done is to provide protection equipment against the pandemic, and they have gone to, say, the hospitals where women are giving births and provided information and protective equipment. So yes, NGOs have played a very important role.
Thank you very much, Graciela. I think we have time for possibly one, maybe two more questions. And I've had one sent in here by another fellow of the Academy, Professor Fiona Stanley, who asks, would Dawn please comment on what the outstanding response of our Indigenous communities to COVID, what that means for ongoing self-determination and enshrining a voice in the Australian Constitution?
Well, that's a big question. Look, I think absolutely know that what it's demonstrated to the Australian government is that the community-controlled health service sector, including NACCHO, which has been around since 1984, they're all non-government organisations, and they have determined themselves how to respond to COVID and the rollout. There's absolutely no doubt in our mind that we need to be recognised as a core part of the architecture of Australia's health system, because we deliver comprehensive primary health care in a way that no one else can deliver it. So, you know, that self-determination that's demonstrated by our sector stands us in good stead for all those international visitors, for a national agreement that was signed by the Prime Minister a year ago to recognise community-controlled health, not only health organisation, community-controlled organisations in this country. So there does need to be, certainly our board's view, the majority of our health sector's view is that we do need to be recognised in the Constitution, and we do need a voice to Parliament. So we've still got a long way to go in terms of, you know, equal access to funding. We do a lot we do a lot for the money we receive, and there are a number of state government-run health services in this country that need to be transitioned to community control because they are culturally safe. We know the whole of our community. We know what we need to do, and so let us get on and do it.
Well, that's a great way, I think, to finish off this discussion. That brings us to the end of our event today. I think one of the big takeaways for me is that the virus itself doesn't discriminate, and we cannot discriminate in our response to COVID-19. Thank you to our panellists, Dr. Dawn Casey, Dr. María, Graciela, Freyermuth, Enciso, as well as Dr. Sergio, Meneses, Navarro, and Associate Professor Margaret Moss. Thank you all, and we do send our best to those in Mexico and the United States during these difficult times. Thank you also to everyone who has tuned in from around the world online. We hope you'll continue to join us for the rest of the webinars in this series. Check the Academy website for all the details. I'm Paul Richards from the Australian Academy of Science. Have a great day.
Science matters to all of us.
We're living in science. We're a world that's driven by science.
A world without science would be a desolate sort of place.
No technology, no electricity, no travel, no planes, no medicine.
A good scientist is someone who can ask a really good question. Once you've answered it, it will have an impact on all sorts of other fields.
With science, you're trying to uncover something no one else has ever managed to discover.
I think the moment of discovery is a really interesting moment. The point where you realise that you're studying something that could be profoundly interesting and you can almost taste the discovery.
It's the biggest buzz you can imagine, the aha moment. That, oh my God, we've got it.
We live in a world of extraordinary challenges. The solutions to those challenges are more science and technology, not less.
If the public have a deeper understanding of science, that allows them to make more informed choices about the way they live their lives, the way they interact with the planet, and being healthier, which ultimately impacts their families and their communities.
The future doesn't happen to us. We get to decide. Those decisions will be about how we best use technology and science to solve the very many problems that are facing us.
We have come a really long way in scientific discovery and innovation over the last 100 years, even in the last decade. But there is still so much that we don't know.
The beauty of the universe.
Understanding the basic building blocks of life.
The beauty of how things work.
With science, you can solve problems. With science, you can make discoveries that none of us could ever have imagined.